Good evening, everyone, and welcome to our Brains Trust Insights St Vincent's, which will focus on neuroscience. Before we begin, I'd like to acknowledge the Gadigal people of the Eora Nation, the traditional owners and custodians of this land, and pay my respect to elders past, present, and emerging. As many of you know, I'm Richard Haddock, the Chairman of the Board of St Vincent's Current Foundation, and I'm delighted to welcome you to this evening's webinar. I would like to welcome and thank our St Vincent's panellists, Professor Bruce Brew, Associate Professor Stephen Tish, and Associate Professor Susan Tomlinson. Unfortunately, Sophie Scott, who generously agreed to facilitate tonight's discussion, has been called away on a last-minute assignment with the ABC. However, we're very grateful to David Factor, St Vincent's Director of Media and Communications, who has agreed to take over tonight's proceedings. Welcome and thank you, David. St Vincent's Brains Trust is a group of leading neurologists, clinician researchers, and neurosurgeons who are striving to realize their visionary goals of improving brain health and ultimately advancing treatments that will bring hope to patients and their families who face the significant challenges of neurological disorders and diseases. The St Vincent's Current Foundation is supporting the Brains Trust with a multi-million-dollar fundraising campaign over the next 5 years. All funds raised will be directed towards priority programs against St Vincent's hospitals in New South Wales and the Peter Duncan Neurosciences Research Unit. In tonight's webinar, we'll hear from our expert panel working on a range of projects across Alzheimer's disease, dementia, Parkinson's disease, movement disorders, neuromuscular disorders, chronic headaches, and migraines. We invite you to participate in tonight's discussion using the chat box at the right-hand side of your screen. A recording of tonight's discussion will be made and sent to you so you can share it with your friends. Thank you again for tuning in this evening, and I'll now hand over to David Factor.
Thank you so much, Richard, and thank you everyone for joining us tonight. We have time for questions at the end of tonight's discussion, so feel free to send your questions through during the webinar using the chat box on the right of your screen, and we'll try to answer as many of your questions as possible. I've done a couple of these webinars. I really enjoy doing them. I feel very fortunate, and there have been some collectively quite a smart bunch of people on the webinars so far, but I think tonight we're safe in saying that we literally have a brains trust with us, and hopefully we'll have an opportunity to really get a really good insight into what's on their minds and share with you some really important and exciting projects that are going on across our campus here at St Vincent's. So on the far right here is Professor Bruce Brew, AM. And Bruce is a consultant neurologist at St Vincent's Hospital and a conjoint professor at UNSW and University of Notre Dame, Sydney. Bruce is head of Neurosciences program and director of the Peter Duncan Neurosciences Research Unit at the St Vincent Centre for Applied Medical Research, the AMR. His research focus covers viral brain infections, Alzheimer's disease, neural stem cell work, and dementia, and he boasts strong partnerships with UNSW, UTS, Macquarie University, which help enhance some of St Vincent's research capabilities. Professor Brew has a strong track record of internationally recognised publications that include over 420 peer-reviewed publications. And that's right, 420, that's not a misreading then on my part. And book chapters. He's also been involved in authoring 4 books, and he is president of the International Society for Neurovirology and part of numerous international collaborative projects and networks across the UK, the US, Sweden, and Italy. Thanks for joining us, Bruce.
Thank you.
Associate Professor Stephen Tish is in the middle, And Professor Tish is a consultant neurologist and head of neurology at St Vincent's Hospital here in Sydney. He's conjoint senior lecturer at the University of New South Wales. He's also an adjunct clinical associate professor at the University of Notre Dame Medical School. Stephen has got a special interest in and expertise in movement disorders and deep brain stimulation. Thanks for joining us as well, Stephen, tonight. And right next to me is Associate Professor Susan Tomlinson. Professor Tomlinson is a consultant neurologist at St Vincent's here in Sydney. Her areas of expertise include neuromuscular disease, epilepsy, chronic headaches, migraines, and pain management. In 2016, her making headway into migraine research alongside co-investigators, Associate Professor Ray Garrick, Professor Brew, and St Vincent's clinical researcher Christopher Rope, was the recipient of the prestigious Professor James Lance Award. Susan is head of the St Vincent's Hospital Chronic Headache Clinic and continues to undertake clinical research in headache and genetic neurological conditions. From 2021, she will add neuromuscular cramps research into her portfolio with a fellowship role funded through philanthropy. Bruce, if I can start with you. And I've got a lot of questions to ask you tonight, so hopefully you'll give me a bit of forbearance on that front. But first things first, what is the difference between dementia and Alzheimer's?
So dementia is a general rubric for cognitive impairment, and it's cognitive impairment that has an impact on activities of daily living. That's the usual definition. So you shouldn't use it indiscriminately. Patients can have some cognitive symptoms, but they're not necessarily demented. Whereas, and there are many causes of dementia. Alzheimer's dementia is one cause. Alzheimer's disease can be manifest as dementia, but it also can be asymptomatic, because we now have imaging tools that, and also spinal fluid analytes that can give us a diagnosis of Alzheimer's, and yet the patient may have no symptoms. Right,
so that means there's people potentially undiagnosed with Alzheimer's and there's no kind of engaging kind of symptom.
There's no clinical expression, and sometimes that can be the case for the duration of their life. But most often it will declare itself at some point, because the actual disease process starts 20 years before symptoms on average. So it's a smouldering process under the radar, so to speak, which then manifests later in most people, not everyone. So you can have, for example, 90-year-olds who pass on, and then at autopsy have a lot of the hallmarks of Alzheimer's, and yet during life they didn't have clinical expression of that. Right. Now, one interpretation of that is, well, they had a lot of brain reserve which can compensate for that sort of burden of Alzheimer's pathology, and they were able to carry on normally. Another explanation is that, well, they were sort of at the tipping point and succumbed before it clinically manifest. If you're a cynic, you'd say, well, the Alzheimer's pathology that we identify now has got nothing to do with the Alzheimer's disease. That's a very contentious issue. But be that as it may, most people think that what we see by imaging and at autopsy equals the disease that we now call Alzheimer's.
So moving on to dementia, how big a problem do you think it is in society today?
Oh, I think it's a huge problem. So it's the leading cause now of death amongst females in Australia. It's the second leading cause of death nationally, regardless of gender. There are 470-odd thousand people living with dementia in Australia at the moment, 15 million in the world. Within the next decade, or well, within the next 2 decades, we'll have over 500,000 in in Australia living with dementia. It has a huge impact economically, $15 billion. $15 billion. Because of work lost, because if you're over the age of 65, 1 in 10 chance. If you're over the age of 85, 3 in 10 chance. So there's an economic perspective from work lost in terms of productivity, but also termination of work. Then the carer burden, both within the family, and then the carer burden in aged care facilities. Not to mention the fact that they become, unfortunately, as the disease progresses, more and more debilitated, and then succumb to, well, not succumb, but they develop a number of comorbid conditions.
I'm on the cusp of turning 50, so this question's front of mind for me, and no doubt many members of our audience tonight. What are some of the telltale signs? And you know, we all get a bit nervous, I think, when there's a bit of forgetfulness. I sometimes completely forget that I've applied deodorant, and you know, minutes later, and there's things like that you kind of, you know, we joke sometimes in society about those telltale signs, but really, what are the true indicators of onset of dementia?
So, in broad terms, it's a combination of things. So within the individual, it's recognising, but not all people recognise, that they've slipped up and become more forgetful. But then that really should be corroborated by family or friends, colleagues. If there's that additional piece of information that, yes, you're slipping a bit, then that's a concern. If it's just, I'm more forgetful, not really backed up by family, friends, colleagues, that's probably okay. There are a number of causes. So you shouldn't have the idea that slipping up, being more forgetful equals incipient dementia. Wrong. Many causes for slipping up, being forgetful, poor sleep, worry, depression, medication effect, all of those rolled in together. So if there's corroborative evidence of something not quite right, then that's the tipping point, I think, to go and say, I should be discussing this with my GP to begin with, and then he or she will evaluate and then hand on as appropriate. I think that's the general way to approach it. Otherwise, you'll have a lot of people who are worried well. And you shouldn't also have the idea that, well, maybe it'll take some time for people to recognise that I'm slipping and therefore I've lost time and therefore I'm on a slippery slope to terrible dementia. That's not true either. It's a slow, indolent process in the vast majority of patients. And if you've noticed that you're slipping and no one's commented, you can ask them, I suppose, and prompt them a bit. But if the response is negative or equivocal, there's no harm in just waiting, perhaps flagging it if you're really concerned with your GP. But the key point is corroborative evidence.
Do you think it's fair to say, Bruce, that if a patient actively reports subjective memory complaints and they're not corroborated, that often that's almost a good sign?
No, I agree, absolutely. And the other aspect, I suppose, is if you know that you're forgetting, you're remembering that you're forgetting,
yeah,
then you're probably okay. Probably.
So you're okay with the deodorant for now? Don't make a habit of it.
That is such a good point. It's funny how, as you do age, and on that point, are there exercises that we can do? You hear a lot of discussion about the brain being a muscle, yeah, and keeping that muscle active. But are there any kind of lifestyle choices that we can make to prevent the onset as we reach our 40s, 50s, 60s, 70s type of thing? Or is that a bit of a fad and, something that we over-focus on?
So there's without question some lifestyle interventions that that do seem to be helpful. And there are some prevention clinics that exist around the world. Only about 5, I think, so far. And what measures? So the usual ones, and there's a heavy vascular risk emphasis, because that seems to be a comorbid, so it's a vascular disease, often goes hand in hand with Alzheimer's. And it seems like vascular disease, if you like, accelerates Alzheimer's. That's at a population level. So what can you do? So no smoking, cautious use of alcohol. It used to be said, you know, some red wine was fine, and it probably is still okay. How much is still, I think, a point of contention. There's increasing evidence that even small amounts of alcohol, even red wine, may not be so good. And then regular exercise, how much? Physical exercise, half an hour a day. What sort of exercise? Again, point of contention, whether it's aerobic or not. And then mental exercise, again, a point of contention. Is there good evidence? Not really absolutely solid. Are you doing any harm? Not really, unless you try and push yourself to the point where you fail, and then you become anxious, and then you become depressed, and then you get even more forgetful because you're anxious and depressed. So you stimulate yourself mentally with trying to learn something new if you can. And then, so those are the general measures. And then hearing is very interesting. It's come up again and again in large epidemiological studies. It's a risk factor, and the mechanism is not clear. It, in one sense, might be that you're not engaging socially, and so you're not getting that stimulation, which is another important aspect to lifestyle, maintaining social contact. And drilling down to why that's so helpful is not clear either. Whether it's the mental effort in engaging in a conversation and keeping up with remembering who's speaking and who's saying what, and the track of argument and so on. But hearing is possibly that, but it's also possibly the apparatus for hearing centrally is very close to the memory part of the brain. And it's biologically sensible to think that if you're not hearing, that those pathways become, if you like, unused, degenerate, and that may have a tipping effect to adjacent areas of the brain. Now that's completely hypothetical, but it's a way of giving some basic science understanding to it, over and above the social context, of course. You know.
So on that note of, because you've transitioned a little bit from lifestyle, going now into your clinical trials work, your research work, talk us through some of the work that you're doing in terms of slowing those pathways and slowing disease progression, because you've had success on the international scale. You've led the way internationally, and we really want to hear about some of these projects that you're leading.
So we'll go from the basic science to the clinical. So the basic science is essentially looking at certain biochemical pathways that are important in the brain, and we're learning and getting some success in manipulating those pathways, and that translates to better energy metabolism in the brain, and that in turn means that degenerative processes as a general phenomenon can be slowed down. That's a bit of a leap, but that's where we're heading. And then we're also looking at brain repair as a more general phenomenon. And we all have stem cells that are resident within niches within the brain. And those stem cells do decline in number and ability to form into proper brain cells as we get older. We're trying to manipulate this particular biochemical pathway to enhance those stem cells, and we've got some success in that regard. So that's the basic science aspect. We're also collaborating with some other groups, most particularly with Bryce Fissel's group at UTS, trying to look at ways of manipulating the synapses and preventing synaptic death. We've got some animal models that explore that a bit further, again manipulating this particular biochemical pathway that can stop not only the toxin, so can enhance the energy for the brain function, can enhance some repair, and can then perhaps stop some of the toxicity. And then in terms of clinical trials, we've got a number of clinical trials looking at various aspects of the disease. So the ones that are really, I guess, most advanced are those looking at amyloid. And I know it's a controversial topic, and there are some doubters in terms of amyloid and its true role in causing Alzheimer's. But you have to, I think, realise that it's got so genetic markers for Alzheimer's are all focused on amyloid. So I think there's a lot of mileage in pursuing that as a therapeutic target. Lots and lots of money has been poured into this, billions of dollars. And it looks like at least one drug may get over the line. We'll know in about 4 months through the FDA. If that does happen, then that'll be a game changer. It's a monoclonal against antibody against amyloid. So it's like you're being almost vaccinated against amyloid. It's not exactly the right terminology, but it's an antibody that then is infused and that mops up the amyloid. And there are those trials. There are several companies that are doing that now, and as a cohort, there are thousands of patients worldwide who've been through these various trials and have actually cleared their amyloid. Got no excess amyloid in the brain at all. It's quite remarkable.
To the degree of reversing disease?
So that's where it becomes tricky. So their disease, this particular drug that looks very, very promising, has slowed, the data are pretty convincing for slowing the disease. So that's a disease-modifying therapy for Alzheimer's, never been done before. Now, can you reverse? I wish, not at the moment. So that's the most encouraging in terms of clinical trials. But there are other clinical trials looking at Alzheimer's, different disease mechanisms. There's an abnormal protein called tau that is involved in causing the disease. And there are some antibody therapies to try and stop that. It's like a domino effect where the abnormal tau resides in the nerve cell, and then it sort of tips a series of dominoes, if you like, a series of other tau abnormalities in adjacent cells, and then it just propagates. So if we can stop that, then that will have an influence on the disease. So that's one aspect. And there are other trials looking at inhibiting some of the cytokines, so immunological chemicals that are important in cellular function and immune function. So people probably have heard about TNF, and there's been a bit of a story over years of having a TNF inhibitor injection. People have gone to particular clinics in the US that have said that they can do it, and it's all been very controversial. However, there are proper trials looking at this, so that's another aspect. And then there's one final aspect that looks at, the energy metabolism of the brain and seeks to enhance that. And that's not to say, then there's a whole new area that's very promising and probably will dovetail into other degenerative diseases called the senolytics. You know, because as you get older, you have senescent cells They're different to normal cells, and they're not dying cells. They're just abnormal cells, abnormal metabolism, and they create an inflammatory milieu. There are drugs now that are in trial that can knock out those cells. If you can knock out those cells, you'll have an impact on a whole host of aging-related disease, including Alzheimer's and Parkinson's and so on.
And in terms of your work exploring those pathways, has philanthropy played a key role? Is that predominantly funded?
Absolutely, absolutely. We would get we wouldn't get to the place we are at now without philanthropy. It's absolutely key. There's no question that governmental funding and pharma funding are important, but the dollar is very, very stretched. And even when you're successful, you are deliberately underfunded. So philanthropy is key.
So you'd put that up there as one of the great enablers in terms of your work?
It is a great enabler. You often have to have philanthropic funding to get either to get started or to have a particular project get up and produce preliminary data. Because you won't get government funding and you almost certainly won't get pharma funding unless you have preliminary data. And if you don't have, so where are you going to generate the preliminary data if you don't have the funding? Yeah.
So on that note, it's probably a good opportunity to chat to you, Stephen, because I know for a fact that one of the big areas we want to talk about today, MRI Guided Ultrasound and the work you're doing on that front, pioneering that technology in the Southern Hemisphere here. I know for a fact that the $6 million machine was entirely philanthropically funded, correct?
That's correct. That's correct.
And so I'm hoping, I know that was literally 2 years ago that that you introduced it along with two of your colleagues, and it's a new treatment for patients diagnosed with essential tremor, and we'll get you to talk through what essential tremor is all about. But I do remember, and it's I've been here 20 years working at St Vincent's, and one of the most poignant memories I have, and it would have been 2 years ago, was a patient of yours with essential tremor walking in the morning, and we were doing the story of 7:30 report, and you asked the patient to draw a circle, and it literally looked like one of those earthquake, not a Geiger counter, seismic kind of, circle. It wasn't recognisable in any way or form as a circle, and sure enough, about 3 hours later after the treatment, you asked her to draw a circle again, and she drew virtually a perfect circle, literally, I think it was 3 hours later. And so I'm hoping you can talk us through MRI guided ultrasound, because if you were to tell me that more than 2 years ago that would be a possibility, I would have told you you're crazy. So if you can explain to the audience, what is MRI guided ultrasound, how does it work, and what disorders or what disease are you using to treat it for?
Sure, well, but I think just before I do that, I saw that lady for her 2-year follow-up a couple of weeks ago, and she is still going strong with fantastic tremor reduction in her dominant left hand, and that's enabled her to resume her artistic activities. She was actually an art teacher, so she can paint and draw and handwrite, and she described it as a miracle when we did it, and she still considers it sort of in that vein, in that it's dramatically reduced her disability from tremor and in a very sustained manner. So I think that's kind of the good story is ongoing. So I thought you'd be interested to hear the long-term follow-up. But what we're doing with that treatment is, we can't claim to have invented it, but we were the first centre in Australia to implement the technology and use it clinically. That was back in November 2018. And basically what it involves is the use of a special apparatus, sort of technology-based treatment, which uses high energy, high frequency ultrasound apparatus. So ultrasound is sound waves, but way beyond the realm of your own hearing. We're actually operating at the level of 650 kilohertz. So it's way higher than you can hear. And that high frequency sound energy, when transmitted through this specialised apparatus, enables multiple beams to be directed through the scalp and through the skull and precisely focused on a focal point. Very similar to a magnifying glass. I don't know if you've ever messed around with a magnifying glass as a kid. You can burn a leaf or burn a piece of paper if you get the focal point correctly focused. But you'll notice you could put your hand out of the focal plane and it's not hot. And the ultrasound's very similar. So where the focused ultrasound beams converge, there is a focalised heating, which can produce a therapy effect, but the rest of the brain is unharmed. So where the beams are just going through the brain but not converging, there's no adverse effect. So that makes the treatment very targeted, very safe, with a very good safety profile, and most importantly from the patient's perspective, it's minimally invasive. So it's actually incisionless. So although we remove the hair and stabilise the head in a little frame with little pins, there's no incision, and certainly there's no drilling into the skull, which is normally required for this type of procedure. So it's been quite a breakthrough in that regard.
And is it just essential tremor, or?
Yeah, mainly. We're treating tremor at the moment. A majority of patients that we've treated, and we're up to about 89 patients now, so we've moved forward with the program, have had essential tremor. Some have had a sort of overlapping and slightly related disorder called dystonic tremor, and then a smaller proportion of patients have had Parkinson's tremor. So we feel fairly confident that it's an effective treatment for all three categories of tremor, but the majority of patients have had essential tremor. At the moment, it's a treatment for one side of the brain to try and produce major improvements in the opposite upper limb. So that's one slight limitation of the technique at the moment, that it's not a whole body treatment for both sides of the brain, but those patients that we've treated unilaterally have all derived substantial benefit for at least one upper limb, which has given them a good return of function and good improvements in quality of life.
With Parkinson's, is movement disorder the main manifestation of the disease, or?
It is. Certainly that's perhaps what Parkinson's disease is most famous for, and most people imagine that Parkinson's disease patients will always have a tremor. The majority have a tremor, but 30% of patients can have no tremor but still meet criteria for Parkinson's disease. So there are other motor features of the disease. A very core one is a special type of slow movement that we as neurologists refer to as bradykinesia, which is sort of really just means slow movement, but it's of a particular type in that repetitive movements tend to get slower and smaller when they're performed repeatedly. And we see this playing out in handwriting, which will typically become smaller and smaller the longer the person writes. Also in terms of brushing someone's teeth, they might start off well, and then the longer they brush, the brushes are getting smaller and smaller, and also steps might get smaller and smaller. So that's a really key feature that we tease out when we're making the diagnosis. But you're right, tremor is an important feature, rigidity, bradykinesia, and then impacts on gait. And then as the disease evolves, we start to see some unstable motor responses, things like off periods, on periods, dyskinesia, dystonia, and then quite a disturbingly long list of non-motor symptoms, which have attracted increased attention in the last 15 to 20 years, and these include things like, surprisingly, losing your sense of smell, being extremely constipated, having a tendency to wild animated dreams at night where you're sort of fighting crocodiles in your sleep. Believe it or not, those symptoms can be important symptoms of Parkinson's disease, and interestingly, those symptoms can exist well before motor features of the disease such as tremor. So we now sort of sometimes identify those symptoms and see them as a potential risk marker or precursor symptom for future Parkinson's disease. And I think those features could be very important, particularly in line with some of the work that Bruce is doing and that we've started to do in our treatment trials, is if you could identify patients with high probability of transformation to Parkinson's disease, but before the motor manifestations are severe, they might be a particularly sort of suitable group to target with disease modification.
And is that a big area, you know, in terms of the horizon for you?
I
in
think
terms
so.
of research and clinical trials?
I mean, we're already involved in that type of work to some extent in that we're a contributing site, and I'm the leading a one satellite for a national initiative called the Australian Parkinson's mission, which is dealing with repurposed drugs for finding disease modification in Parkinson's disease. So unfortunately at the moment we don't have a cure or a disease modifying treatment for Parkinson's, so most of our treatments are symptomatic to reduce symptoms, and there's an urgent need for disease modification in Parkinson's, analogous to the issues with Alzheimer's disease that the work that Bruce is doing. So one very important step in that direction is that there's now a national initiative for which I think there are 6 sites nationally, and St Vincent's is one of them, where we're rolling out different drugs, some of which you can already buy, you can already get, but they've never been tested for this purpose. So that's the concept of repurposing.
So similar to, I mean, there sounds like a lot of similarities, say, in oncology, where we talk a lot in terms of our cancer work on the campus, precision medicine and sequencing and so forth, to look at more individualised treatments. But also there's a big focus, I know, particularly in immunotherapies, of repurposing. It sounds like in the neurological space, it's pretty much the same picture. Is that right?
Yeah, so we're repurposing partly to speed up drug delivery and drug development. These drugs all have some preliminary evidence supporting their potential efficacy as treatments, disease-modifying treatments in Parkinson's, so they weren't picked at random. So they all look promising candidates, but they've never been tested in a sort of a study design which is considered the gold standard, which is the so-called placebo-controlled, double-blind randomised study, where patients will either get the real thing or they'll get a placebo, a dummy medication, and then neither the patient nor the trialists know what they've been given, and then they're followed longitudinally and we look at the outcomes. And if the group that received the study medication are performing better by whatever our study outcome measure is compared to the placebo arm, then we can infer that the treatment was conferring benefit. So that's what we're hoping will happen with this particular study, but we're in the phase of recruitment. We've started, but I think it's a very good initiative and I'm glad we're part of it.
I suspect your answer is going to be quite similar to Bruce's in relation to dementia and Alzheimer's about lifestyle, but in relation to movement disorder, particularly with Parkinson's, what do you see as some of the lifestyle kind of mechanisms that us lay people can kind of adopt to, you know, be a bit proactive in the space? And
yeah, look, I think to maintain a balanced attitude to the disease is extremely important. So not, in a sense, let it dominate one's thinking. It's easy for me to say at this stage as a non-Parkinson sufferer, but I'm also vulnerable. Everyone in the community is vulnerable to Parkinson's. So I sort of empathise with the patients and say, look, it's a serious diagnosis, but I want you to, in a sense, not let it dominate your thinking. I think we would need at this stage to try and manage it, and it should occupy a status similar as a chronic disease, a manageable chronic disease, and you can invest your efforts to try and to manage the disease and remain positive. So that's achieved through a slight attitudinal shift, but also through, these days we use tools like Parkinson-specific exercise and physiotherapy, and there's particular programs that are highly efficient that we refer for, and they do a great job in not only improving motor symptoms measurably, sometimes as much as a medication. So a really noticeable improvement in motor symptoms, but they also improve fitness, muscle strength, joint flexibility. They help combat some of the changes like curvature of the spine and postural changes, and they keep our patients well for longer. So all of those allied health interventions are important. So physiotherapy, exercise programs, appropriate use of occupational therapy, speech therapy to improve voice projection, voice quality. Those things make an enormous difference. And then also little things like paying attention to diet, to not consume excessive quantities of alcohol, to avoid vascular risk factors. All of those things can make a big difference. Looking after one's bowel habit and making sure that constipation is not neglected. Having adequate hydration, because something as simple as being slightly dehydrated can make people feel weary and fatigued in Parkinson's disease. So I think it's not a sideline, it's actually really quite core to get all of those ancillary measures in place. I think you're right.
Yeah, it's fascinating. Susan, you've gotten off lightly so far, but it's time to pick on you now. You know, as I introduced you, you're the head of the St Vincent's Chronic Headache Clinic, and you've got a particular interest in migraine research. So I think a lot of our audience is about to, you know, really kind of take an interest here, because we've been talking a lot about, I guess, what might be regarded as the pointy end of neurological conditions and so forth. But in relation to headaches, I'd love to know two questions immediately. One is, what's the difference between headache and migraine? And number two, what is the impact or the burden on society in terms of both of those?
Thanks, David. So headache is a generic term that refers to pain in the head. Whereas migraine is a primary headache syndrome that is characterised clinically as a severe headache that lasts generally 2 to 24 hours and is often characterised by the intensity. So it's a severe headache that has associated features that includes sensitivity to light and sound, and often associated with a visual aura. So migraine is a subtype of headache, whereas headache is just a generic term for a pain in the head.
Right. The splotchiness that sometimes people get, like there's a bright light on us at the moment, but that feeling of a bright light being on you and there's none, that is a manifestation.
So visual aura is very common. Not all patients experience it, but visual aura is a very common prodromal symptom that can often herald the onset of a migraine.
Right.
It's often one of the warning signs that people experience.
And how prevalent is migraine, or people who regularly experience migraine in society?
I think it's an important point, because migraine as a condition, I think, is really poorly recognised as a significant health problem. And the reason that it's a significant health problem is because it's so common. So 16% of women, 6% of men, around 12% of the population suffer from migraine at some point throughout their lifetime. It's not just that it's a common condition, but it's a condition that continues to affect people over 20, 30, sometimes 40 or more years. And it's most active in the very productive years of life, of vocation and family and personal life. So between the ages of 20 and 50 is often when people are most significantly impaired by migraine. In addition to that, there are about 10% of migraine sufferers develop what we call chronic migraine or daily transformed headache, which translates to about 1% of the population live with a significant disability due to chronic migraine. So it's a really common problem. It's a problem that lasts for a long time, and it can translate to significant disability. But there's very poor awareness in the general community, in the health community, and also in the policymakers as to the significant burden of disease that it translates to. The World Health Organization does a global burden of disease survey every few years, and migraine ranks as the 7th highest cause of morbidity globally across the world. And the health economics relate to not just the direct costs of the illness, such as the medications and the doctor's visits, but the indirect costs with the loss of productivity and absenteeism and so on. It's a really huge issue.
Do you think there's a bit of a perception in society that there's a resignation that we just live with migraine and its prevalence in the community?
Absolutely. I think migraine really struggles to get traction as a serious condition, and even as a medical subspecialty. I think people don't have the awareness of how severe it can be. In neurology referrals to the emergency department, patients coming in that get referred with a neurological condition, migraine is one of the commonest causes that people will go to an emergency department. It's one of the commonest causes that people get referred to a specialist neurologist clinic. And yet I think there's a misperception that it's a benign or a trivial condition.
I've seen that firsthand, actually, and on that note, in terms of the research projects that you're leading on the campus, are you able to talk to us about some of those, you know, which way you're headed and some of the tangible projects?
So there's a couple of things that we've got interest in. One is that I've mentioned that migraine is more common in women, so 16% of women have migraine, and accompanying that are often hormonal influences, and so it's interesting. We're having a look at what kind of hormonal influences can be modified to minimise the impact of migraine. There's a subset of patients that are significantly disabled with headache that becomes entrenched and very difficult to break the cycle. That translates to significant disability and often either not just time off work, but loss of work, loss of identity, and sometimes dependence on medications that might not necessarily be helpful in the long run. So we're looking at various medications that approaches that try and break the cycle of chronic daily headache. And more recently, we're looking at non-pharmacological interventions to try and reduce the impact of migraine, particularly with exercise regimes, and trying to determine, is there a type of exercise that's more beneficial for the migraineur?
What are you leaning towards on that front? Or?
I think it's really important. I think that with people with migraine, there's no doubt that your whole body physiology has an important impact on your susceptibility to migraine, and sleep, nutrition, exercise and mood are all a part of that milieu. If an individual is able to establish a regular exercise pattern, then that has a knock-on benefit for sleep and mood, and all of those issues are part of particularly patients with chronic migraine, part of the disability. So I think it's a much more proactive intervention than taking medication every day, and often one that patients would prefer to engage in.
Yeah, it's certainly more holistic in a way. I think we've got time for a couple of questions. This has been really engaging, and we were meant to leave more time, but it was so hard to kind of cut into this conversation. So we've got a question from the audience. What's the panel's view on spinal cord stimulation? Is that you, Stephen?
I can make a comment. I'm sure Bruce and Susie will have their own views on it. I think it has an accepted role for chronic pain management, and Susie, as a pain expert, would be able to elaborate on that further. Within movement disorders, there's been some interest in its potential use to treat various gait abnormalities, including gait freezing in Parkinson's, and there was some preliminary work coming out of Canada particularly that looked sort of interesting, but it's certainly not completely validated in that capacity. Also, there have been some papers in its potential use for a fairly common but very disturbing movement disorder called Restless Leg Syndrome. So they're kind of the overlaps with my field, but at the moment, for both of those indications, it's still a case of a work in progress. I wouldn't be actively recommending it for those disorders just yet. But for pain, I think it's got an established role. I
think it's certainly one of the treatment modalities that's offered to patients that have chronic neurally driven pain. It's certainly not suitable for everybody, but in some patients that have disabilities stemming from refractory pain who have exhausted other options, it's one of the options. It's certainly not something that individuals would be given in isolation, and it would be part of not just a multidisciplinary team approach, but also part of a pharmacological strategy. So it has its role in selected patients as part of a comprehensive approach to pain, not in isolation.
And on the subject of pain, do you feel like we're making headway in terms of management of chronic pain, or?
I think that certainly the approach to pain management has significantly shifted in the last 5 or 10 years. It's still got a long way to go, and I think it's become well recognised that a multidisciplinary approach that encompasses not just the medication aspect, but also the model of really mood and exercise, nutrition and so on as part of pain management, and trying to break a cycle of disruption of normalcy due to the chronic pain and enable people to return to some regular life despite their pain is certainly advocated these days. I think that the neurally driven pain can be very hard to manage. is certainly something that needs more attention, again, particularly because of the chronicity that's associated with the conditions. We're getting there.
Do you think that people, I think about cardiac health and how there's a communal openness to people making lifestyle kind of decisions and being proactive on that front. The question is, does it happen as much in the neurological space that people are taking that ownership or being open to proactive lifestyle decisions?
Without doubt, and in almost all neurological conditions, there's a very close interdigitation with lifestyle, and we would all work closely with our rehabilitation colleagues and the pain clinic as well. There's a really good collaboration between the three groups. It's essential, really essential in almost everything in neurology.
That's terrific. I've got another question. Are the panel doing Alzheimer's prevention research? This is for Bruce.
So yes, we hopefully in the next few months will be setting up a proper randomised trial to look at Alzheimer prevention. So as I mentioned before, there are 5 or 6 units around the world that have Alzheimer prevention clinics. We are collaborating with a group at Weill Cornell in New York, and they have an approach, a multifaceted approach, which is also precision medicine, where the patients have a genetic profiling for ApoE, for example. That's a genetic risk factor for Alzheimer's, and then metabolic profiling, and so tailor a number of interventions to try to see if that can impact on the progression of Alzheimer's. Now, that's all, so that approach is intuitively sensible, but we don't know really whether it's going to make a difference. So that's the purpose of the trial that we hope to get started in the months to come. The analogy is, we know that interventions work in stroke by virtue of a stroke unit. So no question, randomised trials have shown that stroke units equal better outcome. What the components are that constitute that better outcome, don't know, it's like a black box. So I think that's what we're going to try and model our approach with, that it's a black box of interventions that individually may not make a whole lot of difference, but in aggregate, hopefully will make a difference. But we'll see. I mean, you could be a cynic and say all this focused attention on prevention will attract patients who don't require intervention because they're worried and well. Conversely, you could be a cynic and say the attention to that sort of intervention will increase the anxiety of the patient because you're focusing on the symptoms. And those are valid, potentially valid issues, and I think the only way really to address it is a proper trial, both looking at outcomes that are related to the individuals, but also the more general outcome. Does it have an impact on health economics, for example? So we hope we'll see how things go, but we hope that we'll be able to get sufficient numbers to have some sort of signal. And if it's going well, we may well be able to collaborate and have similar studies elsewhere, perhaps in unison.
We've got time for one more audience question. The audience wants to know about epilepsy. Who wants to lead the way on? Susan.
So again, epilepsy is a umbrella term that describes a situation where patients have recurrent seizures. And broadly speaking, a seizure may occur because of a structural or a structural issue with the brain, such as a tumour or a stroke, or even a metabolic disturbance such as blood sugar. Alternatively, seizures can arise because of an inherent susceptibility to electrical instability in the brain. When that occurs, and that's one of the more common scenarios in patients that spontaneously develop seizure disorders or epilepsy, it's probably not due to a genetic mutation or a condition that they've inherited. It's felt to be due to a combination of complex inheritance of normal genes that are what we refer to as susceptibility genes. And just in a combination in an individual, these susceptibility genes translate to a lower threshold for an individual to have a seizure. Our understanding of seizures or of this kind of epilepsy comes from genetic models, in that there are rare conditions in which a single genetic change or genetic mutation translates to the abnormal neuronal excitability in the brain. And so from that we can extrapolate why individuals with the complex genetic inheritance develop seizures. So a lot of the current research is looking at how to modify excitability within the brain to reduce the susceptibility or the threshold to having an event. The other aspect that is a focus of research is trying to work out if we can detect earlier if a patient's about to have a seizure, which is an interesting area that a group in Melbourne is actually very much focused on at the moment. So it's an interesting area.
I know that you're doing some work in monitoring, like putting in monitors similar to a pacemaker that intervenes for neural abnormalities. Can that be applied for epilepsy as well, potentially?
So certainly. So we're not doing it at this campus at the moment, but there's two ways in epilepsy that can be monitored. In patients that have refractory epilepsy, one of the clinically available assessment tools is to put in intracranial grid monitors to try and determine if there's a focus that's potentially resectable or treatable to reduce the frequency of seizures. The second aspect is that patients can have implantable brain stimulators to try and determine whether or not a seizure is about to occur or if there's a specific focus. So it's a really interesting area of seizure assessment that's continuing to evolve.
And Stephen, do you think there's some overlap here and opportunity with some of the work you're doing in deep brain stimulation?
Yeah, I think the stereotactic interventions that we have well established in movement disorders have application to epilepsy. There are already some FDA-approved DBS indications for epilepsy, and there's actually been some patients within Australia. There's some Department of Health legislative reasons why epilepsy DBS is a bit complex in New South Wales, but in Victoria a number of patients have had DBS for epilepsy, and with promising results. So I think there's a scope for increased uptake of deep brain stimulation for epilepsy in the future, similar in the way that we've successfully applied it to many movement disorders.
I think I'm being told to wrap up. We've slightly gone over time, but I can't begin to tell you how extraordinary this conversation's been, and I can't speak for the audience because I can't see them, but I have no doubt, and not just judging by the questions, but just judging by what you've covered today, how engaging and how important this is for all of us. And we're incredibly grateful for this work that you're doing. But particularly tonight, I just want to thank you for making the time and the time to explain things so clearly for all of us. A lot of these issues are I was saying when I met Susan tonight, it's great for an area that's so kind of commonplace to understand. But all of you have described fairly complex kind of areas in a way that all of us can understand, and we're truly grateful for that. But particularly grateful for all the work that you do as the Brains Trust on this campus and the endeavours that you're doing in that space. On that note, and Bruce, you touched on it, perfectly in terms of philanthropy being the great enablers and the differentiators on this campus that have enabled all three of you to go on to do the extraordinary work that you're doing. And to this end, I am aware that the St Vincent's Curran Foundation are playing a critical role in really creating that fertile ground that the three of you are exploring in your research teams. And I know there's an ongoing campaign that's been led by the St Vincent's Curran Foundation. This isn't just a short-term kind of endeavour on their part. They're in for the long haul, as I understand it, and tonight is kind of a clear indication of that. And thank you for sharing, you know, the journey that we're on. You know, this is really exciting times for this campus. So thank you for joining us, and thank you to our audience for being with us tonight, and thank you to the St Vincent's Curran Foundation. On behalf of all my peers across the campus, we're really grateful for you being the great enablers for all that we do. Thank you.
Thank you. Thank you, everyone.